Hello, welcome to today's video. We're going to be looking at hypernatremia. So as always, let's get started with the definition. So the definition of hypernatremia, simply put, is whenever you have a sodium concentration of greater than 145 millimoles per liter. And this is also known as a hyperosmolar state because by definition, if you have high sodium, you have high osmolarity, and so then you have a hyperosmolar state. So real quickly, let's take a look at osmolarity and what it is. So here is an artery, or a vessel actually we should say. So this is a vessel, and then adjacent to the vessel, so in this area here next to the vessel, we have a row of cells. And fluid is present inside this entire area. So this area within the cell, within the vessel is known as the intravascular area. The area between the vessel and the actual cell is the interstitial area. And the area within the actual cell is the intracellular area. Intracellular area. So cellular, I'll just report compartment. So when we're talking about fluid, fluid again is distributed through this entire area. So the intravascular compartment and the interstitial compartment, this is known as extracellular fluid. Extracellular fluid, also written as ECF. Okay, and then the intracellular compartment here is known as the intracellular fluid, and this is denoted as ICF. Now you may be wondering, well, why are these two areas combined as this is not? Well, the biggest reason why we consider the intravascular space and the interstitial space as the same is because fluid moves freely. So water, all the electrolytes, glucose, everything moves freely in these two compartments. However, that's not the same in the intracellular compartments. Some things cannot move into the intracellular compartments, and so this is highly selective in what comes in and what goes out, including the electrolytes and the osmotically active agents or electrolytes that we'll talk about in a little bit. Now, although it looks like you would think that the extracellular space is larger than the intracellular space, that's not true. There's actually, when it comes to fluid, there's more fluid in the intracellular space than there is in the extracellular space. And actually there's double. So on average, the average person has about 14 liters of fluid here and about 28 liters of fluid in the intracellular area. So you can see it's almost double. So you have about 66% here and the rest 33% there. And then when it comes to between intravascular and interstitial, most of the fluid would be in the interstitial area. So the interstitial has about 10 liters, whereas the intravascular has about 4 liters. And this is the actual part of the blood which maintains your blood pressure. So this is the part that maintains your blood pressure, and when we talk about blood volume, this is the area we're talking about. And whenever you talk about edema, you're talking about too much fluid in the interstitial area. So now when we're talking about water, water gets to choose. Water can choose either to be in blue here would be your water molecules, either to be in the intravascular area, it could choose to be in the interstitial area, or it could choose to be in the intracellular area. Where it goes, it depends on where it prefers. So with the place where it prefers is wherever there's the highest solute. So in the actual extracellular fluid, the solute that is most active is sodium, whereas in the intracellular area, the solute that is most common is potassium. So when you have a large amount of sodium formulating inside the intravascular area, well, what does that do? Well, what's going to happen is the water molecules are then going to rush out in this direction, right? So all the water is going to go into the intravascular space, and then cause to try and dilute the sodium that's concentrated. Now, if we talk about the reverse, if you remove the sodium, then you have low sodium, then the water will move in the exact opposite direction. They'll go inside the cell and cause the cell to get more edemacious. So you can see that the biggest factor that maintains water within the vessel or in the cell is going to be sodium. However, sodium isn't the only piece of the puzzle. There are two other substances which can influence water. So we also have glucose. So glucose is also going to maintain water inside, and we have BUN. So BUN will also maintain water inside the intravascular space. So these three molecules put together will determine what is the plasma osmolality. And so when we write the plasma osmolality, so the plasma osmolality equals 2 times the sodium. So why is there 2 times the sodium? Well, sodium has a positive charge. So whenever you have a positive charge, there has to be some negative charge that's associated with the sodium. And this could be bicarb, this could be chlorine, this could be many other things. However, it's not just one thing. So instead of trying to figure out all the things that would be associated with this, we just double sodium to take that into consideration. Okay, and then we go ahead and then we add glucose divided by 18 and BUN divided by 2.8. So when we're dividing, we're just changing the units. So just make sure that your BUN and your glucose is in milligrams per deciliter. And so when you plug in this formula, that'll give you the plasma osmolality, and the plasma osmolality generally tends to be anywhere between 270 to 290. That's your normal plasma osmolality. And when you have that amount of plasma osmolality, you're normal. You don't feel thirsty, and you'll be fine. Now, one thing also to mention here before we move on, BUN is sometimes also known as the ineffective osmole. And so what does that mean? So why is it called ineffective osmole? The reason why it's called ineffective osmole is because it can actually go freely inside the cell. So BUN can go freely inside and out. However, glucose and sodium can't. They need to go through specific channels, otherwise they get turned away. So what is the big deal here? Well, what this means is the reason why it's called ineffective osmole, since this can shift in and out of the cell. Well, if you ever have a shift in water, BUN will shift to adjust itself to water. So it doesn't necessarily move water in any direction. So what you want to remember is it does not move water. And this is because it can move itself instead of causing water to move. Whereas sodium and glucose, if you have a lot of water, within the intravascular space, it's not going to adjust itself by maybe going more into the intravascular space or going more into intracellular space, and so it'll cause water to move, not itself. And so that's why there's another formula which is called the tonicity. So when you look at the tonicity, so when we're looking at the plasma tonicity, it becomes the same formula. So we have 2 sodium plus glucose divided by 18, but you can notice, let me shrink it here. Okay, so you can see this is the same formula here, except it's missing the BUN. So this is BUN here, and there's no BUN there. And again, plasma tonicity kind of is focusing more on osmoles that actually move water in one direction or another, and don't change don't move itself to adjust with water. So this is just a general overview of osmolality, which does become important when we're talking about problems with sodium. So now let's go ahead and get started into the pathophysiology of hypernatremia more specifically. So hypernatremia can occur because of 2 broad reasons. Either there's going to be a decrease in the total body water without the sodium, or there's going to be an increase in sodium without a subsequent increase in water. So either of these 2 scenarios will lead to hypernatremia. And so what happens, how does the body react to hypernatremia? Well, when you have hypernatremia, it activates osmoreceptors in the hypothalamus. And the idea is, the current theory is that in these osmoreceptors in the hypothalamus, when the blood becomes hypernatremic, they quickly become dehydrated, and kind of like mechanoreceptors, they trigger the hypothalamus to go ahead and act. So this trigger usually occurs when the plasma osmolality is anywhere between 280 to 290 milliosmoles per liter, and as the osmolarity steadily increases, then the amount of ADH and thirst that's produced is going to be the same. So, like I just mentioned earlier, the reaction it has is either by generating the feeling of thirst by the patient or increasing the ADH. Now, thirst is we always get thirsty, but it's a very strong way, a very effective way of managing hypernatremia or sodium levels in the blood. It's so effective that if it's intact and the patient has access to water, it's almost impossible to get hypernatremia. So it's a very effective way of maintaining sodium balance. The other way we maintain the sodium balance is by increasing ADH. So when you increase ADH, you increase free water reabsorption in the collecting tubules of the kidneys, and this is done with expressing the aquaporin channels, which will reabsorb the water. And since you're reabsorbing water without sodium, you are effectively decreasing the amount of sodium concentration and causing hyponatremia relatively. So this is the way that your body reacts to a state of hypernatremia. Now, what I also want to do when it comes to the pathology is regulation of brain volume related to sodium, because when we talk about the clinical symptoms, it's all pretty much related to the brain, all the symptoms. So what I'll do here is I've drawn a brain cell, and here I've drawn a blood vessel. So normally we have a certain amount of sodium in the blood vessel. However, when you get hypernatremia, this will lead to some changes. So water will go away from the neuron into the interstitium and then over into the vessel, and this can lead to dehydration of the cell. So as you can see, the neuron there is dehydrated. So acutely by I mean within 2 days, the initial stage you get dehydration of the cell. However, the neuron is surrounded by electrolytes, and so when it gets dehydrated, then suddenly you have a high concentration within the cell, and so these electrolytes will then begin to move into the cell, and as they begin to move into the cell, the water will then follow, and so as the water follows, this can lead to a partial. So that as water goes in there, it can lead to a partial restoration. It's not enough to completely restore the fluid in the neuron, because of course it's not going to be able to offset sodium, but it can do it partially. So this is in the acute stage within 48 hours. However, if it goes in a chronic stage, and this usually happens when you have mild hypernatremia, chronic stage is after 2 days, you get the movement of organic osmolytes. And organic osmolytes are amino acids such as glutamic acid and glutamine, polyol, and methylamines. So these are all neurotransmitters and different substances, and they can then start drawing into the cell, and this can help the brain cell return to normal size. So osmolytes together with electrolytes can help offset hypernatremia if given enough time and it's not severe. So that's the pathophysiology. Let's talk about the various causes. So the causes are divided into 3 groups. Either hypovolemic, so the patient might be dehydrated, hypervolemic, where they might have too much fluid in their intravascular space, or euvolemic, so they have the normal amount of fluid in the intravascular space. So how does a patient become hypovolemic? Well, this is pretty much they lose more water than sodium. So it's not necessarily they're not losing sodium, it's just that they're losing more water than sodium. Hypervolemic is going to be due to any type of sodium retention. And finally, euvolemic is when you have a loss of sodium without water. So they're able to maintain the blood pressure and the volume, but they're not able to keep their sodium levels. So let's first take a look at hypovolemic. So these causes are grouped into non-renal and renal. So generally, non-renal will have a urine sodium of less than 10, because again, the kidney's working, so it's reabsorbing the sodium, so you shouldn't have too much sodium in the kidneys. Whereas renal would have a urine sodium greater than 20, because that's where they're losing their sodium. So when you're thinking of hypovolemic non-renal causes, this is things such as sweating, which occurs due to exercise, osmotic diarrhea, now not secretory diarrhea. So osmotic diarrhea is like lactose deficiency and some of the bacteria that causes osmotic diarrhea, like giardia. Secretory diarrhea, like what do we have? Cholera. Yeah, so secretory diarrhea like cholera, they tend to be isotonic. And since it's isotonic, it's not going to be able to create any type of hypernatremia. And so it's very important to make a distinction between the two different types of diarrhea when we're looking at hypernatremia. Also, patients who are not drinking enough water, so decreased water drinking and thirst can also lead to hypernatremia. Now, when we talk about these three, the people who are most at risk are the elderly and the debilitated, because generally when you have these symptoms, you will get thirsty and then you'll want to drink water. However, elderly people and people who are debilitated aren't able to do that oftentimes, and so they're the most susceptible. And a good way to know whether this patient has any of these three conditions is the urine osmolality tends to be greater than 800. So they're really trying to concentrate the urine to offset the loss. Also, pancreatitis, burns, and trauma are other causes of hypovolemic hypernatremia. Renal causes, here's when people are taking too much diuretics. So diuretic excessively can do that, and especially osmotic diuretics. These would be things such as mannitol, can lead to too much loss of fluid. And also adipsic diabetes insipidus. So adipsic diabetes insipidus is when not only do they are not releasing enough ADH, but they're also not able to get thirsty. And so since they're not getting thirsty, then they tend to lose all of their fluids. And so this is conditions such as septo-optic dysplasia and different types of brain tumors in the thalamus can lead to this. So that is hypervolemic. Now when we talk about hypervolemic, again, this is a situation with there's sodium retention. So again, we have non-renal and renal. So in non-renal, the forced excretory sodium is greater than 2%, and in renal, it's going to be less than 1%. So iatrogenic causes, so these are caused by doctors. Sometimes when we're treating metabolic acidosis, you give the patient sodium bicarb, and of course sodium bicarb has sodium in it, and so that sodium, oftentimes if you treat too much, can lead to hypernatremia. Hydrated cysts, which occurs generally in the liver, when they treat it with hypertonic saline solution, and that helps kind of dehydrate the cyst. So oftentimes that can be absorbed into the vessels and then lead to hypernatremia. Abortion as well. In abortion, they tend to use intrauterine hypertonic solution, and again, that can be absorbed into the vascular system and then lead to hypervolemic hypernatremia. And finally, very rare cause, but salt poisoning. This can be either accidental or apparent, during child abuse. And there is actually a Turkish custom where they put salt all over the baby's skin for some reason. So that's something to just to kind of have in the back of your mind, I guess. And then renal causes is going to be high aldosterone. So as you know, aldosterone reabsorbs sodium and at the same time reabsorbs fluid. So it's a very common cause, like Cohen syndrome. But these patients will also have low potassium because, of course, you get potassium excretion. Euvolemic causes, this is generally diabetes insipidus with patients who are drinking enough water, but they're not drinking solute. So they're only drinking water. And so in these patients, the urine osmolality will be less than 300 because they can't concentrate the urine. And also hypothyroidism actually can cause euvolemic hypernatremia. So those are different causes. Now let's go over the symptoms clinically. So again, when we talk about pathophysiology, we split them up into acute and chronic. And so acute is generally less than 48 hours, and chronic is considered greater than 48 hours. So in acute, you generally have a very rapid decrease in brain volume. And so this rapid decrease in brain volume can lead to rupture of some of the bridging veins of the cerebrum, and then that can lead to subarachnoid hemorrhage. You can also get demyelination of the brain lesions, demyelinated brain lesions, as sometimes you get when you treat hyponatremia too quickly. So what type of symptoms do patients actually get? Initially, they'll get lethargy, weakness. They may even have some irritability. So that starts when it's mild. When it gets more severe, they have obtundation and decreased level of consciousness. That tends to happen. And when it gets really severe, they can get seizures, coma, and eventual death. So this is a deadly condition. Generally, when they get to about 158 milliequivalents per liter, that's considered severe. And if it gets to 180 milliequivalents per liter, then there's a very high mortality. So you really need to be careful with those patients. Now, when we're talking about chronic, the change in hypernatremia is occurring at a much slower rate. And so since it's going much slower, the brain it's less likely to cause severe symptoms. And this is simply because since the hypernatremia is occurring over a much longer period of time, the brain is able to slowly and steadily adapt to these changes. So in patients with hypernatremia, what lab would you want to do? Well, you want to look at the serum and you want to look at urine. In both of them, you want to look at electrolytes, in particular sodium, potassium, and calcium. However, in the urine, calcium probably isn't as necessary. You want to check osmolarity in both serum and urine, and you want to definitely compare the two. And when it comes to serum, you definitely want to look at glucose and urea so you can calculate the plasma osmolality, and then creatine for renal function and ADH in case you're thinking of diabetes insipidus. Also, with urine, you do want to check the urine volume over 24 hours, and that's going to help us when we're calculating things later. CT and MRI is a good idea if you're thinking of diabetes insipidus, and this you want to do with the brain to see if there's any lesions that you might be able to find. Okay, so now that we've done that, let's go on and take a look at treatment. So the treatment is going to differ whether you're dealing with chronic or acute hypernatremia. And again, chronic is when you have greater than 48 hours, and acute is when it's less than 48 hours. So chronic, you generally want to correct slowly because again, the brain has adjusted to the change in sodium. And so if you correct too quickly, that can cause edema. So again, correct slowly to prevent the onset of edema. Whereas in acute, you want to do rapid correction because the brain hasn't adjusted to the high sodium, and so you want to try to prevent any neurological damage from occurring that if it hasn't occurred already. So the treatment, you can tell, is very different whether it's chronic or acute. So generally when it's chronic, you want to decrease the serum sodium less than 10 milliequivalents per day. So you don't want to do more than 10 milliequivalents per day. And per hour, that'd be 0.4 milliequivalents per liter per hour. So that's what you want to do in chronic. Again, don't go above that. Any faster than that, and you can lead to cerebral edema. However, in acute, you want to get them to normal sodium levels within 24 hours, no matter what it is. So you're moving much faster. And so how much sodium do you need? Well, generally they say 3 milliliters of pure water per kilogram will decrease sodium by 1 milliequivalent per liter. So if you want to decrease the sodium by 1, you got to add 3 milliliters of water per kilogram. So that's a general formula there. So what are you actually going to give them? So for chronic, you're going to give them IV dextrose 5 water, and you're going to give it at a rate of 1.35 milliliters per hour times whatever kilogram they have. So generally, patients are between 50 and 70 kilograms. So if they're a 50 kilogram patient, that's around 70 milliliters per hour, and if they're a 70 kilogram patient, it's around 100 milliliters per hour. So anywhere between 70 to 100 in the average patient. Now, if it's acute, then you want to do more than that. You're going to want to give the same IV dextrose 5 water. However, instead of giving 1.35, you're giving 3 to 6 milliliters per hour times their weight. So triple to 5 times more. Then what you want to do, because you're giving such a high amount, you want to go ahead and monitor every 1 to 2 hours until the sodium is below 145 milliequivalents per liter. So once you want to rapidly go down to 145 milliequivalents per liter. Now you're worried about overcorrecting. You don't want to go into hyponatremia. So then you start giving 1 to 2 milliequivalents per liter per hour until it's restored, until the sodium level is restored. So that's how you treat acute. With chronic, you do want to continue monitoring, but you can monitor for 4 to 6 hours. And if you're not hitting your target, then you probably need to just add more water because you have some type of water loss going on, either urinary or somewhere else. Now, where do we get all these numbers from? What's kind of the rationale that we're using? So you can go ahead and memorize those figures. They'll generally work, but it is a good idea to know what you're actually trying to do. So the way we get those numbers is, first you need to calculate what is the water deficit. And so the water deficit is calculated by getting the total body water times the serum concentration divided by 140. So that's the percentage that you're off by, and subtracting it by 1. So as you know, how do you calculate total body water? Well, we can't calculate it directly. There are some formulas that you can use. So total body water is usually 60 to 55% of the body weight. So generally, this is for young adults, however, and the 60 is for males and the 55% is for females. However, in elderly people, you're probably going to be looking between 50 to 45% males to women, and even less. The percentage is even less if they're obese. And actually, I think it's 40%. So if they're obese, then it's even less. So, for example, if you have an elderly woman who's 60 kilograms and she has a sodium level of 168 milliequivalents per liter, in this case, to calculate the water deficit, you're going to first figure out the total body water by multiplying the 40% times 60, and then you're going to take the 168 divided by 140 and subtract 1. And so what you're going to figure is 4.8 liters. So this patient is missing a total of 4.8 liters of water, and you need to go ahead and give them that much water to bring the sodium concentration back to normal. So now that you figure out, okay, this is how much water I need to give, now you need to figure out, well, how quickly do you need to give it? And so you have to design some sort of regimen to do it. So again, with chronic, we're not trying to exceed 10 milliequivalents per liter. So what we do is you take the water deficit that we calculated earlier, so the 4.8, you multiply it by 10 milliequivalents per liter, that's the maximum you don't want to pass, and then you take the serum sodium minus 140, which is normal. So you just find the deficit in the sodium, and that tells you how much to give them in 1 day. And so if you want to figure out per hour, you can just divide whatever you find 1 day into the hour. And for acute patients, remember, you just want to get this total deficit in 24 hours. So you can just go ahead and take whatever water deficit they have, divide it by 24 hours, and that's how much you should get per hour. So it's much more simpler and straightforward with acute. So now on top, well, many patients, especially if they have diabetes insipidus or any other conditions, they're actually losing water as you're replacing it. So you do need to add any ongoing water loss that's going on. So you do need, for one of the places where you lose water is sweat and stool. So you calculate about 30 to 40 milliliters per hour for that. And then for urine, you take the urine volume that we talked about in the labs, and you multiply that by 1 minus the urine sodium and urine potassium, and divide it by the serum sodium. So when you do that, you get a specific volume, and you want to add that volume to whatever you're already giving to take that into consideration. So, and that's pretty much how you manage these patients with hypernatremia to get them back to normal natremia. So do remember, you do have a risk of hyperglycemia. You are giving dextrose, and so after a while, especially if they have diabetes or they're under stress. So sometimes if patients under stress, like in trauma, they have high epinephrine, high cortisol, and that can trigger hyperglycemia as well. And so in these patients, you just want to switch to either a 2.5% dextrose water, or you can dilute it. You can dilute just a 5% dextrose water. So that's one way of doing that. Also, if patient has diabetes insipidus, you can try adding desmopressin. That tends to help as well. So this was the end of the lecture today. So I hope you enjoyed it, and I hope to see you in the future videos. Take care.